Good afternoon. I'm Kevin Ness from Vanderbilt University in Nashville, Tennessee in the United States. Again, I wish I could be there with you. I spoke yesterday about COVID-19, and today I want to talk to you about seizures and epilepsy in children. Now, I've talked several times over the years at this symposium about seizures and epilepsy, and I want to focus the talk today about outcomes. And one of the fundamental questions patients and their families will ask us is not only what is going on with my child, but how will they be in the future? So I've tried to think about good outcomes and bad outcomes and why we think that's the case and how to make those distinctions in the patients. I generally think of seizures in general themselves as underlying different forms of epilepsy as being two different types, the big buckets. One bucket is a focal or partial seizure, meaning they're starting from one part of the brain and then usually spreading. And then generalized, also known as genetic epilepsies, by EEG and clinical definition, really involve the whole brain at one time. And a good example of a focal seizure type, which I'll talk about underlying a focal epilepsy, is benign Rolandic epilepsy or benign epilepsy with central temporal spikes. And a good example of a generalized epilepsy is childhood absence, which every pediatrician I'm sure is familiar with. And those are both good examples of outcomes, which I'll characterize in the slides by a green thumbs up arrow. Why is it good? Because one, you normally should grow out of it. You will stop having seizures and not require medicines, and that is the example for benign Rolandic epilepsy as well as absence seizures. But also you have good cognitive outcome. You should be a normal human being and function well. In contrast, the red down thumb is because you will not grow out of your seizures and because they will usually leave you fairly either devastated or potentially lethal seizures, or at least leave you with cognitive impairment and really not be able to live the life that you want these children to live. So I think these are the important outcome questions which I'll highlight as I go. I mentioned this type already. It has several names, which are actually pretty good names. Benign Rolandic epilepsy, the Rolandic part of the brain, I'll show you in the next slide, is the central temporal region of the brain, hence the next name, benign epilepsy with central temporal spikes. And again, the word benign here literally is there because it means you're going to grow out of it and you should do okay. There's always exceptions, but for the most part, this is not the worst thing to have. So this definitely gets a green arrow up. It's an example of a focal type seizures, and it has a fairly classic presentation. Children at nighttime often come to their parents making facial grimacing and guttural type sounds. And it's because, again, the central temporal region of the brain also has a lot of motor involvement that controls both the face as well as throat musculature. So it makes sense that a seizure in that area would present those symptoms. And these are generally not that common. Everyone should grow out of it by the time you're 16. In fact, one of the axioms is if you don't grow out of it, you were probably misdiagnosed to begin with, since everyone usually grows out by the time they're 15 or 16 years of age. And some patients actually don't even get treated with medicines because we recognize this as a benign entity and the seizures may be rare. But most patients, at least the ones that I see in a clinical practice, because they've had enough seizures to warrant that referral, usually are on a medication, but again, we don't put them on the strongest, most side effect medication because we expect them to do well. So here's this reminder that the central temporal region of the brain is reasonably here, and these minus and plus signs refer to the next slide with the EEG, because there's a particular electrical polarity we see. So if you're an EEG reader, you can see the typical EEG of benign Rolandic seizures, and it has this characteristic morphology. So given the right age, given the right seizure type, a neurologist or you could reasonably diagnose benign Rolandic epilepsy or benign epilepsy with central temporal spikes and have a good outcome for this type of epilepsy. The next example is always hard to spell, but I can say it now, Panayiotopoulos Syndrome. This is a relatively undiagnosed disease of children with epilepsy that's more of a focal feature again, but it has a very different EEG signature. But again, it gets a green thumbs up, and I think hopefully my video hasn't obscured the arrow here, but this slide in my version has a green up arrow going from there. Why? Again, because patients grow out of these conditions and seem to be pretty normal human beings when they're older. This has more posterior occipital discharges, so it's often associated when you start with more vomiting. It's also nocturnal. The eyes may be moving in certain ways. So this is clearly something's going on with the child, but they may be misdiagnosed for a while. They're thought to have a vomiting syndrome or a migraine equivalent, but the EEGs are quite striking if you have it, with very posterior discharges. I'll show you in the next slide. And while we think this is very genetic, we haven't really figured out the genes yet. One of the reasons is just practical. Again, people grow out of it, so again, it's not the worst thing out there. And then these EEG discharges, to me, say that the O is the occipital electrode, so further back in the head. And just as an interesting point of discussion, as these patients get older, while they start off with these classic symptoms of vomiting nocturnally, as they get older, their EEG discharges move in the brain, actually become further and further anterior, and then they go away. So I don't quite know what that means, but it's important to know then your patient's age as well as when they present. Here's another example of the same thing, a posterior discharge in the back, and then over time becomes more widespread and more anterior. So those are two examples of relatively good outcomes. The next one is not good. So anytime you have half the brain involved, something probably not good is going on. There's always exceptions, but generally not good. So this is giving me a down red arrow. And here's the EEG, and you don't have to be an EEG reader to know that this is the left and right side of the brain and the left and the right side of the brain. There's a clear asymmetry here. The left side has slower waveforms than the right, so there's some difference. And it can be actually hard sometimes to know which side's abnormal, but in general, the slower, bigger waveforms is usually the abnormal side. But these are an example of a patient who will get brain imaging to sort out what's going on. And then there's a differential of what can be happen. It can be something, again, bad. These are generally, again, thumbs down, tumor, stroke, brain malformation. But we also see it with patients who've had a seizure on one side of the brain, and that side of the brain is just not recovered yet. And even with migraine headache, you can theoretically see. So that's the one exception, that a hemispheric dysfunction may not be as horrible as you thought. But in general, if you have something that's involving one complete side of the brain, that's usually going to be a thumb down, bad outcome. Here's an example of some brain malformations. You can see here, this is the right side of the brain in this patient, this large overgrowth. This is called hemimegaencephaly, whereas this side just didn't grow well. This side's causing a lot of seizures, and the poor other side of the brain, flipped of course in radiology, this is the left side of the brain, is really being squished by the other side. Not good. Another example of a patient of ours who had an inflammatory disease on the right side of the brain. See this increased white area in both the axial as well as the coronal section. And this patient probably had or was developing a condition called Rasmussen's encephalitis, which is an autoimmune inflammatory disease. And if it gets bad enough, it can really take over one side of the brain. This patient had surgery ultimately with a resection of those areas and actually did quite well. But these patients can also, again, progress with more issues. But again, this is an example of a not great outcome because you had to actually have epilepsy surgery urgently. The next example is good for board questions, I think. We don't see these pictures anymore, but there's some calcifications here in the brain. You see the so-called railroad track pattern, and then you can see that here's a diagnosis of the port wine stain on one side of the face, and then the thickened meninges. So this, of course, is Sturge-Weber syndrome, which, at least the patients we see, tend not to have good outcomes. One side of the brain is very involved, and they often have seizures and cognitive delay over time. And then the EEG from it, again, this is non-specific, but one side refers to the left part of the brain here, when the odd numbers and the even numbers are at the right. This is very asymmetric, so something different to the left and right for these brains here. So again, this is the example, Sturge-Weber, of unfortunately a down, usually bad outcome. So the next example I'll give is a generalized seizures, and I mentioned this earlier as an example of, in generally, a good thumbs up seizure type to have, which is the childhood absence. Now that was a simplification because some generalized disorders are not good, so this is a mixed one, both thumbs up and thumbs down. And it really gets into what type of syndrome you have. So I kind of have a spectrum here. Absence being the best one because why? You grow out of it and you have normal cognitive development, to bad things like Lennox-Gastaut Syndrome, Infantile Spasms, things you do not grow out of and always have cognitive delay and many of these patients actually have shortened lifespans as well. And a whole variety of other myoclonic epilepsies, again, other examples of generalized disorders. But let's start off happy with a thumbs up green, which again is the childhood absence I mentioned. And again, this is pretty common, so I'll go through it quickly in the interest of time. I usually think of this as the United States, kids go to kindergarten age 5 or 6 years. So that's usually when these seizures occur, and the patients unfortunately are accused of not paying attention and having attention problems, and that's often can be the case, but also maybe because they're having frequent absence staring seizures. This is a very easy diagnosis to make with the EEG. This is a typical 3 hertz spike and wave. I won't show an example, but it's pretty easy to diagnose. So any patient who's staring, you should get an EEG if possible to look for this, because it's pretty easy to treat, and again, they have a good outcome. It's not as easy to treat or not as good outcome if they're not diagnosed and not treated with appropriate medications. Any of the medicines listed here, lamotrigine, valproic Depakote, ethosuximide, or even Keppra, all are reasonably good first choice drugs, and most of them work well with some exceptions. Again, everyone grows out of this by the age of 12, and usually before then too. So again, if you had to pick something for a loved one to have, epilepsy for childhood absence is not that bad. There's a version of this called juvenile absence epilepsy, which EEG looks very similar. The medicines treated are all very similar too, but for some reason this is probably a different disorder, because a lot of patients do not grow out of juvenile absence. And just to keep it straight, the patients with juvenile absence are starting to have seizures at about the ages where the kids with childhood absence have grown out of them or are about to grow out of them. So they're epidemiologically pretty easy to separate. And these patients also have more other types of seizures: grand mal, generalized tonic-clonic seizures, myoclonic seizures. So there's another condition called juvenile myoclonic epilepsy, or JME, I'll talk about in a couple of minutes. And these patients actually may have that too. They may have just had the staring spells when they were younger, but then they developed the myoclonic seizures. And since they're all generalized seizure types, they then later get a diagnosis of JME with the myoclonic features present when they're older. And it's important because, again, both this entity called JME as well as the juvenile absence, one thing they do share is you usually do not grow out of them, or you're not expected to. So again, it's just the way it is, and you need to give the family the appropriate information so they can plan their life. Here's one EEG of a very classic 3 hertz spike and wave, and this could be a childhood absence or a juvenile absence. And when we see this, it's just very clear about what's going on in terms of diagnosis. So I called JME here both a thumbs up and a thumbs down. Thumbs up because you have normal cognition, thumbs down because you don't grow out of it. So it's kind of a mixed bag, but most patients, as long as they take their medicines, avoid things like not sleeping well, taking drugs, things of that nature, usually can be very well controlled. And again, they usually start this a little older age too, 12 to 18, so it really overlaps that juvenile absence. And one of the teaching points is you have to ask them about the myoclonus, which is a little jerking. They might just think they're clumsy and they make a little movement, but that's actually an epileptic manifestation. If you ask the question, do you spill things in the morning, are you clumsy? If they have JME, it's actually surprising how often they endorse those sort of symptoms. But again, it's not a terrible thing to have. Most people have this, have normal cognition. They do well, they go to school, but you're not going to grow out of it spontaneously. And the EEG also is a little bit different. I don't want to take too much time, but EEG readers can tell the difference between a generalized epilepsy that may be a myoclonic epilepsy versus an absence epilepsy. The patterns are just different, and we can tell that. Next one is for sure a thumbs down generalized epilepsy, infantile spasms, and most pediatric neurologists are obsessed with this disorder, including me. Why? Because we see them too often and they have a pretty bad prognosis. And while we're starting to understand more, it's still a diagnosis you hate to make, because you know this child very, very likely is going to have a poor outcome. So they're infantile spasms because they happen in infants, usually around 6 months, but they can happen a little earlier, a little bit later. They have this classic flexion sort of spasm. There are many videos online you can refer to about this. They usually cluster. There's something developmentally going on pretty clearly. The family knows there's something going on with the child, and usually have a poor prognosis. In the United States, we use a lot of ACTH and other forms of steroids, but also a drug called vigabatrin. Other things listed here can be very effective short term, but long term, many of these patients do not do well. You may see if you get an EEG, this particular diagnosis of hypsarrhythmia, which really just refers to a very disorganized, abnormal pattern. There's also something called electrodecrement. If the patient has their actual spasm, it's actually occurring right at this point in time. And when that happens, the whole EEG kind of goes into this sort of stealth mode. There's a lot of activity, and then right here it gets very quiet for a few seconds and picks up again. And this is important because there's some other seizure types we'll talk about next, which can have the same electrodecrement patterns. So Lennox-Gastaut Syndrome is definitely, I gave it actually 2 down arrows because you don't grow out of it, and by definition, bad cognition. These are the patients you may see who wear helmets because they fall down and have head trauma due to their atonic seizures. They collapse and they fall down. They also have tonic seizures, they get very stiff, and then they have some staring type seizures as well as generalized tonic-clonic seizures too. Most patients have these every day, multiple times per day. By definition, all these patients have intellectual disability, and they should start before the age of 10 to get to full Lennox-Gastaut syndrome. There's been many medications that have been approved for this condition, and while they can be helpful in controlling the number of seizures, they don't really change the overall outcome. So we need much better understanding and much better treatments for this. But just the usual medicines listed here. We also have some surgical techniques, including the vagal nerve stimulator and a corpus callosum, as well as diet therapies too can be considered. A couple of EEG patterns. You have, unlike the 3 Hz spike and wave and a generalized absence, this is slow spike and wave. So if I had a time measurement here, it's about 2 discharges per second. And that in the EEG world is a big difference, 2 versus 3. 2 is a bad outcome, 3 may be a better outcome. And then curiously, a lot of patients who had the prior discussion point, infantile spasms, when they were younger, they had these seizure types, and then when they got older, they developed more seizure types, and then they got a label of Lennox-Gastaut syndrome. So they're probably both epileptic encephalopathies with age-dependent manifestations. And one of the EEGs we see in the patients with Lennox-Gastaut, when they have those either falling down atonic seizures or stiffening tonic seizures, is this pattern here, again, which is electrodecrement, just like one would see in the infantile spasm. So electrically, there's some clues as well too, but either way, this is definitely 2 thumbs down disease, Lennox-Gastaut syndrome. So other single gene disorders are listed here. I definitely give them a thumbs down. So SCN1A, sodium channel, we see fairly often, and any sort of genetic epilepsy panels will have this gene on it for sure. The most common bad one is called Dravet Syndrome, also known as severe myoclonic epilepsy of infancy. Pretty good descriptive name, I must say. But it's of interest to me and others because this same gene, SCN1A, depending upon what type of molecular change you have, whether it's a missense mutation or a deletion, you could have a milder form or a more severe form. So there's an interesting genotype, phenotype, and again, if we're trying to talk about outcomes, this GEFS Plus version has a much better outcome than the Dravet syndrome side of it. So again, not only knowing what the diagnosis is, not only knowing what the gene is, but what the particular molecular detail is can inform your discussion about whether this is a thumbs up or a thumbs down. Skip through this. Multiple medications can be used for the severe form, Dravet syndrome. Again, they can be helpful in terms of seizure control, but again, they're not going to change the overall developmental outcomes, which is by definition poor. Okay. So some other syndromes I'll mention here in closing, just to be complete. These are, again, generally bad things. Unfortunately, we see bad things at times. One is a neurodegenerative disorder of children, the NCLs, neuronal ceroid lipofuscinoses. There's some glimmer of hope on the horizon. There is a new gene therapy approved this year for the CLN2 gene, which causes some NCLs, but there's other genes, and most of them don't have therapies, but people are definitely working on it. Angelman syndrome is an important disorder you may see that has much more molecular diagnoses. Again, don't really have great therapies yet, but people are working on it. And then we're going to start to see more of the measles-associated SSPE, subacute sclerosing panencephalitis. older pediatricians may remember this entity, but I worry in the world of, at times, less vaccines in general, we may see a resurgence of both measles outbreaks, and with it will then come SSPE, and these, again, overall fairly bad things to do. So, again, I thank you for your attention. I'd be happy to address any questions via email. I hope I see you in person next year, God willing. And then I found this picture from years ago. I just wanted to share it, of Dr. Guthrie there. I kind of look like him, I think, a little bit. It must be the beard. And of course, Dr. Bill Russell, who you all know, who is probably given the most lectures of anyone. But again, I really look forward to coming back in person to Amman and seeing all of you. So thank you for your attention. Shukran lak.